Good morning. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks for joining us today for what is our 7th webinar as part of the Fall SRS webinar series. The fall lineup does include 11 talks over 11 weeks. So if you haven't already, I do encourage everyone to visit the fall.srs-webinars.com website to review the future talks that we have in store for you. And through this website, you can also register to view recordings of prior webinars as well. One item of business before we get started. If you'd like to submit any typewritten questions at any point during today's talk, you can do so by using the Q&A button found at the bottom of your Zoom console. And time permitting, your questions will be addressed by Dr. Yang at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife system, and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler, over to you.
Thank you, Mark, and good morning or good evening, wherever you are in the world today. So I'm delighted to be able to introduce today's speaker, Isaac Yang, who currently is Associate Professor of Neurosurgery, Head and Neck Surgery, and even Radiation Oncology. He's a trifecta at UCLA School of Medicine. Isaac is a noted and accomplished clinician and surgeon, as well as a researcher in the translational field. Of note, he originally hails from Northern California. I just found out Lodi, California, and not many in the world know where Lodi, California is, but it's here in Northern California, tucked away in a small little town between Sacramento and San Francisco, and I find that notable. However, I'm sure that good country stock has made Isaac in part the surgeon he is today. And we're going to hear from Isaac about the latest update in radiosurgery for acoustic neuroma. Take it away, Isaac.
Good morning. I'm Isaac Yang, and thank you, Dr. Adler, for that kind introduction. I'm coming to you from UCLA, and I'm really excited to talk about a topic that's near and dear to me and that I'm very passionate about, which is the treatment for acoustic neuromas and radiosurgical treatment of them. I'd like to thank I'd like to thank Dr. Adler and Zap Surgical for giving me this chance to talk about radiosurgery. Dr. Adler is always on point. You can see him even when we were in Brazil at the Christ Redeemer statue. He's branding with the Z hat there. And Dr. Adler is easily probably the most innovative neurosurgeon of the modern era or of our lifetime. And it's such an honor to, I mean, this was a bucket list, to get a picture with him and get a picture with him at the Christ Redeemer statue. And so I'm very thankful to both Dr. Adler and Zap for giving me the chance to talk about acoustic neuromas. And acoustic neuromas are a kind of a misnomer because these tumors are not actually from the acoustic nerve, they're from the vestibular nerve, and they're not really neuromas, they're actually schwannomas. But these are the most common tumors in the CP angle. And these tumors deal with two nerves, is that they are adjacent to the facial nerve and to the cochlear nerve. And so these two things, the facial function and hearing function, become principally important in the treatment of acoustic neuromas. And I'm going to start with how do we look at these tumors, how do we treat them, and how do we preserve hearing? And I hope to come full circle at the end to look at the future directions of how we're going to save hearing, treating them with radiosurgery. But I think before you treat these tumors with radiosurgery, these acoustic neuromas or vestibular schwannomas really ought to be evaluated with observation. And I think this is going to become more and more important as we diagnose more, as MRIs are now very, very prevalent. 20 or 30 years ago, MRIs were cutting edge, but now they're so prevalent, we are having more and more incidental findings of acoustic neuromas. And so the first consideration has to be observation, that some of these tumors may not need to be treated, that perhaps less is more. But when you do observe these tumors, if they have a growth and a growth rate of approximately 2 millimeters per year, these tumors are likely going to be the ones that need to be treated. And 20 or 30 years ago, it was a little more controversial whether or not radiosurgery was appropriate for acoustic neuromas. But I think now in 2020, it is well established that radiosurgery is a very viable treatment option. And I would argue either equipoise or perhaps even gold standard for people who have small tumors or people who are older. That radiosurgery may actually be the first-line therapy now for small tumors and patients who are older. It's like how coiling has really pushed open neurosurgery to equipoise and maybe to the side of it, that radiosurgery is now really going to become gold standard or first-line therapy. And 20 years ago, when I first got interested in acoustic neuromas, I went to the first place that young neurosurgeons should, which is the literature. And I pull up these two papers, not because of anything in particular, although they're good papers, but just because on PubMed, they were the first two papers that came up at the time. They were side by side. And if you look here, it says the hearing preservation without diagnosis of NF2 was 98%. And I said, that's fantastic. Radiosurgery, you get a 98% hearing preservation. And then the very next paper, it said that 50% of patients had useful and maintained service hearing. And as a young neurosurgeon, I was almost distraught and dismayed by the wide variance in the literature. And when you looked at, there were so many papers and so much history, a lot of it on Gamma Knife, which was the initial technology. But a lot of these studies were from single institution, and every institution is biased. I'm not pointing to any institution in particular. I'm pointing to my institution. I'm pointing to UCLA or UCSF, where I was prior, is that every institution has bias. And it's really hard with these tumors that are rare, that you can only hit numbers in the hundreds, that it's hard to reach the statistical significance to make really big observations and impacts that can change clinical outcome. And then the methods of assessment were subjective. And so we started with a systematic analysis. We tried to pull the data together to do a meta-analysis. And this was with my former colleague, Dr. Andrew Parsa. We were trying to limit the error that's inherent in any particular study. We were trying to limit the institutional bias and aggregate these numbers. And so we aggregated almost 6,000 patients treated with radiosurgery. And we found that if you treated with less than 12 gray or 12.5 gray, you had better rates of hearing preservation. And this made a big impact because when we looked at all the data, the average marginal dose was actually quite high. That in the 80s and 90s, people were treating the 14 gray and 16 gray. And that really, if you treat it to 12 gray or less, and that's really the modern, if you look at the modern standard, most centers are now treating the 13 or 12 gray in single fraction, that keeping that dose lower rely to better hearing preservation. And the ENT literature is well established with the Gardner-Robertson and the AOS hearing scale. And using this either on an audiogram or functional hearing, we're able to see that hearing preservation is better with lower doses. And we published this almost 15 years ago now, at looking at this overall analysis, that when you treat acoustic neuromas with radiosurgery, you want to preserve hearing and you want to keep that dose less than 12 or 13 gray. The other nerve that's important is the facial function. Acoustic neuroma treatment should all be about facial nerve preservation. And when I do surgery for facial nerve preservation, it's really important to keep the face intact. Well, radiosurgery is phenomenal for this. And at UCSF, we only had a Gamma Knife. And so we were looking at the Gamma Knife technology for facial nerve preservation. And the facial nerve preservation is greater than 96%. And I'm at UCLA, and over the past 10 years, in the hundreds of patients we've treated, I'd say our facial nerve preservation is approaching 100%. Is that it's exceedingly rare to have any facial nerve injury or a decrease in House-Brackman score with radiosurgery to acoustic neuromas. And so if you want to preserve facial nerve function, radiosurgery is going to be a phenomenal impact to how you treat these tumors. And facial nerve outcome is the biggest determinant to quality of life outcomes. If you want to impact quality of life, decreasing hearing, yeah, you take a quality of life impact. But if you cause facial nerve dysfunction, it's an enormous quality of life impact. And we found that when the dose was less than 13 or 12 gray, the facial nerve is actually quite robust. It's the motor nerve function here. And so it's very robust to radiosurgery. And so we published this as well about a decade ago as well, that facial nerve is extremely robust. And just like how we can't change the language and the common language of acoustic neuroma, even though it's actually a vestibular schwannoma, we can't, the language hasn't shifted. Around this time in 2008, 2010, the three bodies, CNS, Astro, and AANS, they came together and said, if the fractions are 5 fractions or less, we're going to define this as radiosurgery. And if the fractions are greater than 5 fractions, we're going to define this as radiotherapy. And at the time, I was younger, and I thought, you know, this is going to happen, and we're going to have consistency and agreement, and we're going to all be able to use the same language to describe fractionation and radiosurgery. And 13 years later, the terms radiosurgery and radiotherapy are still being used in different ways, and different fractionation schedules are being referred to differently, and that this has not taken on the uniformity that I thought it was going to take on 10 or 12 years ago. But when I came to UCLA, I wanted to look at this radiosurgery and radiotherapy difference in looking at hearing preservation. And so with Dr. Michael Selch and Dr. Antonio de Salas, we looked at a whole cohort of patients who were treated with radiosurgery to 12 gray and radiotherapy in 28 fractions, most of these patients. And these patients were similar in overall outcomes in terms of their age and their sex distribution. And so we looked at their overall outcomes, and what we found was that radiotherapy, the fractionation, had better hearing preservation than the radiosurgery. Two things I want to point out is, if you look at the single dose radiosurgery, hearing preservation was still 60%. And that was consistent with the data that we had published a decade earlier, that about 60% hearing preservation is what you see with single fractionation. But if you do the radiotherapy, 28 fractions, we found that hearing preservation was much, much better. And so this was really the new finding, that this was statistically significant. And, you know, I did a lot of my previous research in gliomas, and we do a lot of actuarial actuarial graphs to see when patients would die from glioblastoma. Well, we just did that exact same analysis, but for hearing preservation, and we were looking at when did the hearing go down in these patients. And we found that after about 10 years, the hearing loss was actually a wash between radiotherapy and radiosurgery. So that hearing preservation was better with the multi-fractionated radiotherapy with the 28 fractions, but that effect washed out at about 10 years. After 10 years, either due to lack of follow-up or some confounding factor, the hearing preservation rate dropped at the same rate as a single fraction. But if you want to preserve hearing for the first initial 10 years, radiotherapy proves to be better than radiosurgery. And we published this a few years ago, and it was given this award, the Cynthia Skullbase Award. The next thing was to try to understand, well, why? Why was a single fraction worse for hearing preservation than radiotherapy? And what we had to go back and do was, for all of these 212 patients or so, we went back and did their cochlear dosing. We reevaluated all their treatment plans. It's a fair number of work. And we looked at the radiosurgery and radiotherapy plans. And this wasn't done automatically at the time. And so what we had to do was, on the CT scan, we had to contour the cochlea to initially find out where the cochlea was going to be. We would then fuse that to the MRI and look for the T2 signal. And that allowed us to get the most accurate cochlear contouring we could. Once we contoured the cochlea, we looked at the mean cochlear dose. And we found that if the cochlear dose was held to less than 8 gray, you had better hearing preservation. So that the hearing preservation in patients who had cochlear higher than 8 gray, that this was not so good for hearing. But when we held the cochlear dose to less than 8 gray, the hearing preservation was better. And this changed our treatment paradigm, is that for patients who are going to get single fraction, we got an audiogram. And if their hearing was intact, we tried to keep their single fraction less than 8 gray. We're actually now in the second phase of the study, and we're actually finding that it's going to be lower than 8 gray. And the preliminary data suggests that keeping it less than 6 gray or 5 gray is going to be even better for hearing preservation in a single dose. And we use this 8 gray as a marker because as a lot of you on this call will know, is that when you do optic nerve preservation, you try to keep the optic nerve or the optic chiasm to less than 8 gray for optic nerve preservation. And so it made sense that the cochlear dose should be less than 8 gray. And really, it should probably be less than that. And we hope to put that out there soon. And we published this paper as well, this cochlear dose paper with Dr. Selch, Dr. DeSalis, and the whole radiosurgery team at UCLA. And you can look at that data for the details. But radiosurgery doesn't always work. It works most of the time. And I would concur that it works 80 to 90% of the time, but that's not 100%. And this is one of the earliest case reports that I published in a gamma knife case series. You can see the tumor here. And after the gamma knife radiosurgery, the tumor expanded. And we can have another talk and webinar about dosing and fraction and the heat in the middle and the expansion that you see. But regardless, it expanded here. And then it required expansion after shrinkage that required surgery. And so radiosurgery doesn't always work. And so there's a whole nother frontier of, well, why doesn't it always work? Is it the biology of the disease? Is it the treatment method, the fractionation? And so that's something to evaluate. And then the next logical question is, well, how does it compare to open surgery? And this is a group from UCSF that looked at their hearing preservation. And if you look at the tumors that are less than 3 centimeters, the hearing preservation is about radiosurgically comparative, is that about 70% of these patients were able to preserve their hearing compared to about 60 or 70% in the single fractionation. But once the tumor is bigger than 3 centimeters, the hearing preservation falls to less than 50%. And this is a UCSF series. And we recently did a meta-analysis of all patients being treated with retrosigmoid craniotomy and trying to preserve hearing. And this was recently published in the Red Journal. And if you look at this series, this revalidates that data. If you look at intracanicular tumors, the hearing preservation is almost 60%. But as soon as there's any cisternal component and the tumor is small, hearing preservation falls to 40%. And if the tumor is larger than that and larger than about 1.5 centimeters, you're not going to save hearing. It falls down to about 15%. So with open surgery, you have an 80 to 90% chance that you're going to lose substantial hearing. And so I think that radiosurgery, at least from the data, is safer for hearing preservation than surgery. And the real question is observation safer for hearing than radiosurgery? And that's going to be something I think we're going to figure out in the future. One of the things about facial nerve that we do in our imaging is we wanted to know, could DTI help us localize the facial nerve? And so we did a study, a small study to do this, and we found that we actually can visualize the facial nerve now. But we found out that it makes no difference in how you treat these tumors, and it makes no difference in the clinical outcomes. But it makes for really nice images. Here you can see the tumor, and you can see the facial nerve where we expect. Even here, it's even prettier. You can see the facial nerve draped across anterior, right where you expect it to be, and so it makes really nice images. But we have found that it makes no difference in either the surgical treatment or the radiosurgical treatment for these tumors, and that was a publication that we also published here. But ultimately, it still comes down to trying to be the best doctor, the best neurosurgeon, and the best radiation oncologist that you can be. That trying to find the best management paradigm really comes down to knowing your patient, listening to your patient, and knowing that for each one of our patients, they're going to value these different outcomes differently. They're going to value hearing preservation, facial nerve preservation differently. That the age of our patients are going to be different. The size of the tumors are going to be different. Their comorbidities and quality of life. And it's really going to be a very individualistic therapy. And that's why I really like acoustic neuromas, because it forces me to be the best doctor I can be, to take that time to listen to the patient, understand their anxieties, understand their goals, and try to give them a treatment option that really maximizes the best treatment for all of them. I think the next frontier, and I do not want to call it the final frontier, but the next frontier is, how do we treat these acoustic neuromas to save hearing? And can we treat cystic acoustic neuromas? This is a recent publication from the Pittsburgh group looking at cystic acoustic neuromas. And there's data now both from the Pittsburgh group and the Mayo group that suggests that cystic acoustic neuromas may be the best targets for acoustic neuroma therapy. And this is difficult for me to comprehend and accept because in my whole training, they always said, do not treat cystic acoustic neuromas with radiosurgery. It doesn't work. But that paradigm may be wrong. That might be outdated and historical because there's a growing body of evidence that suggests that cystic acoustic neuromas may be targetable and treatable with radiosurgery. And I think this is going to be one of the next frontiers and a really interesting question to look at. One of the other next frontiers is, so we think that radiosurgery is better for hearing than surgery. And I think that's pretty clear from the data. But what's not clear is observation better for hearing than radiosurgery? Should we do an early radiosurgery to try to preserve hearing? And there's less data on this, but there is emerging data. This is from Dr. Rajiv's group looking at early gamma knife surgery versus an observation to preserve hearing. And their data suggests that early radiosurgery preserved hearing better than watchful waiting. And this is really an exciting, controversial, and also paradigm-changing thought on how to treat this. Their data is not alone. This is also from the Pittsburgh group looking at early radiosurgery. And here they had similar results in a large series of 88 patients that early radiosurgery was better for hearing than late radiosurgery. And so I'm not sure how that compares versus watchful waiting versus late radiosurgery versus never doing radiosurgery. But this is really an interesting question. And for the younger radiation oncologists and neurosurgeons in this audience, I think that's the next question to pursue and try to answer, because this could really change how we treat those early diagnosis patients that perhaps when I started about hearing preservation and observation, maybe I'm wrong. And maybe that isn't the best way to preserve hearing. Maybe it's going to be earlier radiosurgery. And honestly, I don't know, but I'm really excited to find this answer over the next 5 to 10 years, because I think we're going to answer it. I don't do this in a bubble, although I am sheltered in place. I do this with the whole brain tumor team here at UCLA. I have a whole team of young, smart people. The future is so bright. These are members of the Yang Lab who do the majority of this hard work and heavy lifting, and I'm forever grateful to all the people pictured and listed here, and to the funding that allows me to do my work. And if you have any questions, please bring them up now so Dr. Adler and I can talk about them. And if you're old, you can email me. And if you're young, you can direct message me on social media, but I'm always available for questions. Thank you.
Isaac, great. It was a brilliant and review of where radiosurgery is for acoustic neuroma today. And I note you've contributed to a lot of this understanding, both yourself and your work at UCSF and with your colleagues there and now at UCLA. So great stuff. So I'm gonna start asking a few questions. Opening to the audience, others to ask questions as well. So, I mean, Isaac, the data I think is incontrovertible that cochlea dose matters. But the dose also correlates with the tumor location. And is the tumor deep in the canal really the same tumor that is then therefore adjacent to the cochlea? Is that biologically the same, or is it is the failure to preserve hearing with those tumors entirely because of the cochlea dose, or can it not also be the location of the tumor as well?
That's a really good question, and that's a really big question. It's a fantastic question. It's a big question because we're finding that we can't discern when size and location matters. We don't have that data granular enough to determine that, and so we brush it aside. But does it matter? It probably does. And even clinically, sometimes we will see tiny tumors, really small tumors in the canal, and these patients present with complete hearing loss.
Right,
So
right.
the size doesn't matter there, and then somehow maybe the location matters. But conversely, I'll see patients who have ginormous tumors. I mean, just, I can't believe they're walking and walking in kind of tumors, and their hearing is perfect. And so I do think size and location matters, but we just haven't discerned it. And I think it matters more for radiosurgery. You're absolutely correct. Is if the tumor is close to the cochlea, we cannot contour it. And right now, we actually try to contour to preserve the cochlea. When it's near the cochlea, we contour just like the optic radiation and the optic chiasm and optic apparatus. We contour to preserve the cochlea, and that's a function of distance and location. But if you cannot preserve the cochlea and you cannot contour around it, I think, and I don't know, I think our data suggests that fractionation may be better or safer for hearing than lower fractionation schedules. And so I think that. I don't know that, but I think that, and I think the data suggests that. And that also makes sense just from, how we treat other tumors in higher fractionation schedules. And so, although that isn't clear, if you cannot preserve the cochlear dose, then I would advise or advocate to moving to a fractionated schedule, because it appears that the fractionation is less detrimental to the cochlea dosing.
So that leads me to my question. So is that the dividing point between when to fractionate and not to fractionate cochlea dose? And so yes, you've shown data that's relatively compelling that there's a difference there's an advantage to fractionation, obviously in a pretty heterogeneous group of patients. So which patients do you fractionate, which do you not, and is it related entirely to cochlea dose?
Again, that's such a good question. I think let's just say you drink the Kool-Aid, you buy the Isaac Kool-Aid, and you're like, that's great, let's fractionate. You should fractionate everyone. If I were to argue against myself, I would say, Isaac, there's two problems. Number one, if you fractionate everyone, that's super inconvenient. That's just not going to work. I mean, I have certain VIP patients that fly in and they dictate their treatment. They're like, I'm not fractionating. I don't care what you say, just single dose me because that's all I have the time for. And so one, it's super inconvenient if you go to the 28 fractions. And then the second question is, what's the right fractionation schedule? I mean, this is a comparison of 28 and 1 mostly, but is it 3? I'm sure, Dr. Adler, you'd say, why not 3? And I would say, you're right, why not 3? And I think right now they're also looking at 5. Why not 5? And if you're going to say 5, well, why not 8? Why not 9? Why not 6? And if it's 28, could you come down to 27? But do I think in general, is that spirit correct? I think in general, even if 28 is not right, I think the spirit is correct, that probably 2 is better than 1, and 3 is probably better than 2 and better than 1. But what is 5 better than 1? Probably, maybe. Is 5 better than 3? I don't know. Is 8 better than 5? I don't know, but I think the spirit is right. But we don't know what the number
here's a question. So Isaac, you have a small tumor, 1 centimeter, doesn't involve the canal at all. It's all in the cistern. Would you fractionate or would you do a single fraction?
So the first thing I would do is I would watch.
Okay. Fair enough.
The patient's age or young, old, 1 centimeter, whatever the hearing status is, no matter what, I would watch. The second thing is I would get the hearing tech. And I'm assuming you're going to suggest that the patient's hearing is perfect.
Good hearing.
Yeah. And so then if it's cisternal and the patient's hearing is completely intact, I would watch. If the tumor showed small growth or the patient really wanted this treated, I would tell them I would recommend fractionation because it suggests that that's the safest way to preserve hearing. Now, there's no data to that, but that's completely like if it's my own head, basically. If it's my own head, I would be willing to trade 5 weeks of my life for even the feeling or the smallest statistical chance that could somehow improve my hearing. Now, if you look at the data, the cochlear dose is going to be low, and so you could single fraction that, and it would suggest that that would be the same. But I'm a very anxious, nervous human being, and so I would recommend fractionation.
Well, you bought the fractionation Kool-Aid, I can see that. And so, yeah, so I mean, the way I came up with 3 fractions is actually dates back to the frame days before I even had a CyberKnife. And so I reckoned that I could keep a frame on someone's head in hospital for 36 hours. And in 36 hours, we could give 3 fractions. And so that's not a very intelligent way of going about deciding a fractionation regime, but that's what was decided.
Because that's so well ingrained in the data. And so then I think of Dr. Adler and your innovations and your like Nobel Prize caliber thought. And I thought, well, you must come with 3 in some scientific way. But when you tell me that makes sense, that it wasn't really science behind that. You thought that's the most you could keep a patient in a frame in the hospital. And so that's why it came up to be 3. And so that makes perfect sense. And yeah, I think 3 is going to be better than 1.
Okay, well, I'm waiting for you young guys to figure out the magic recipe. And I'm hoping that bigger and better registries, which is something we at ZAP are very interested in, and trying to generate large numbers of patients with long-term follow-up, because you need really 10-year follow-up, I think, and if not 15 or more to make some of these intelligent decisions. Isaac, hemifacial spasm doesn't happen. I know I agree that a true frank facial nerve injury with radiosurgery is almost a 0 event. But I have seen a small handful of hemifacial spasm cases, and it freaked me out. And I'd like to see, have you had some experience with it? And the reason to talk about it is not so much that we have the answers, but someone in the audience may see this and they'll feel a lot better knowing what the life history of this is. So hemifacial spasm after radiosurgery for acoustic neuroma.
Yeah, all the other complications. So you're right. I think facial weakness is a near 0. I've seen 2 Bell's palsies that came and then went. And it's hard to tell whether it was Bell's palsy or from the radiosurgery. And just like with the hemifacial spasm, which I've seen one, it's hard to know, was that the natural history of that human being already? And what I've actually seen more of, which is also, especially very early in my career, was really nerve-wracking, was the post-radiosurgery hydrocephalus. You have a sizable tumor, you do the radiosurgery, and the patient's completely asymptomatic, but they end up with post-radiosurgery hydrocephalus. And early in my career, I'd only read about it. And then when I first saw it, I was just losing sleep because I was convinced the patient was going to get hydrocephalus or get headaches or need a shunt or something. And I wasn't sure what to do. But now that I've had, about half a dozen of these patients, you just watch them. But it's, I think if you're going to trace it back, you have to compare the incidence of hemifacial spasm, normal pressure hydrocephalus, and Bell's palsy against the natural incidence of these other diseases in the non-treated group. And I think you're going to find them that they're going to be pretty comparable. And that just like you have to compare the incidence of naturally occurring malignancies compared to the malignancy induced from radiosurgery, they're going to be fairly comparable after 20 years. And so I don't think or know that radiosurgery by itself is not causing these things, but I don't think it's playing a substantial role in some of these other outcomes.
Okay, well, I mean, I tend to disagree because I've had a few cases that have had hemifacial spasm a year after radiosurgery, and I mean like 3 patients, but it was quite severe, and it was managed well with Tegretol, and then we weaned it after a few months, and they went on to live a happy life without hemifacial spasm for 10 years or more. I don't know what they're doing today. So,
you should compare them.
So I think there is a connection, but in my experience.
You should compare them to your fractionated group, Dr. Adler.
Oh, okay. Well, I'm not saying, I don't know that the treatment per se is responsible, but it certainly did control the symptoms. Sure. And it's a complex, milieu, as you pointed out. What's treatment, what's tumor, what's location, what's age, what's biology. So, but here another really vexing problem, I think, in a lot of acoustic neuroma patients is vertigo. You know, these patients present with vertigo often, and rarely does radiosurgery make it better. I notice you're not just a neurosurgeon, but you're also a head and neck surgeon. So you're as close as I get to the triple threat with neurotology knowledge. So any special recommendations for that post-radiosurgical patient who has really bad vertigo?
Yeah, so that's a really vexing problem, and it's much, much more common. You're absolutely right. Vertigo and the balance is extremely common with the acoustic neuromas, and radiosurgery very less than the majority of the time makes it better, and in some cases can actually make it worse. And I think this is why acoustic neuromas have to be a multidisciplinary team. You have to have radiation oncologists, neurosurgeons, and ENT doctors. And yes, so what we do and what I do with my ENT colleagues, Dr. Geffen, he was on my thank you slide. We treat these patients with low-dose gentamicin injection, and it works. You know, if you look in, neurosurgeons, we don't treat Meniere's very frequently, but in Meniere's, they used to do vestibular nerve sectioning to help people with balance. But if you have an acoustic neuroma and you get treated with radiosurgery, really my hypothesis is that your balance will ultimately improve because the balance dies out in that bad ear. And so that's what the radiosurgery helps accelerate. Well, a low dose gentamicin injection over 5 days into the ear, it's an outpatient procedure. If you do a high dose gentamicin, that's ototoxic. You lose hearing, you lose everything. That low doses, you just ablate the vestibular nerves. And that's fantastic because if you kill all the vestibular nerves on the side that has the acoustic neuroma, as long as you don't have an acoustic neuroma or vestibular issues on the contralateral side, these patients' balance, they get significantly better. And so I treat the tumor control with radiosurgery. I treat the balance with low-dose gentamicin. I treat them as separate things and ask the patient, what is it that you want? And if they just want balance improvement, I send them to Dr. Geffen, and we do that. And we really should write that up because that's a appreciated therapy for that.
You should, because I have no experience with that, and I love the idea. I love the idea. And I got a good journal for you, by the way, Curious. We'd love to publish that. So yeah, you just touched on another issue of interest, bilateral acoustic neuroma and NF2. And I mean, if things aren't challenging enough with unilateral tumors, bilateral pose a whole new order of magnitude of complexity. So any principles for approaching patients with NF2?
Well, I think NF2 is a totally different beast. I think two things. One, you have to preserve function at all costs. I mean, that has to happen no matter in any case, but particularly in NF2. I think the biggest impact we can make in our NF2 patients is teaching them American Sign Language as early as possible. Mm-hmm. And then the last thing is, I think because most NF2 patients are younger and have been treated by neuro-oncologists and hem-onc and med-onc therapy, there's a real bias against radiation and radiosurgery in NF2 patients. But if you look at the literature and you talk to doctors who treat NF2 and you look at the surgeries that we do, if you really compare it against the facial nerve outcomes and the surgeries we do, I think that radiation is either going to be equipoise or just below it, to where you really have to weigh the cost benefit, the outcome benefits of radiosurgery for NF2. And so I think radiosurgery is absolutely on the table for NF2 patients with acoustic neuromas. And I know that's a controversial stance and not everyone shares that opinion, but I don't think it's completely like erratic or wrong or it's definitely not malintended, but it's my firm belief that I think radiosurgery is on the table for patients with bilateral acoustics NF2. And if anything, it makes the contouring and the radiation dose easier because the two tumors are close by. And so if you can contain good tumor control rate with NF2 with radiosurgery, I think that has to be considered as much as surgery and its facial nerve outcomes with NF2. And yes, the patients are younger. So when the patients are more adults, now I'm not talking about pediatric patients because I don't do pediatrics, but for older patients, I think it has to be something to be considered. The outcomes won't be as good. And there's some literature that suggests that perhaps maybe a slightly higher dose will achieve better control in these particularly difficult patients. But I think radiosurgery should be considered. And I think there's just been a long historical bias against radiosurgery because most of these patients were young and children. But I think that's absolutely a field that radiosurgery, as it gets better and there's more data, and like you said, if you want to criticize me, and I appreciate you not criticizing me, my data outcomes are 4 to 8 years. That's a big hole. If you were looking for the hole in my data, is that our outcomes are not long enough, and that's really hard to follow. And you're right, we need 8, 10, just like I showed on the actuarial curve, we need 15-year data on these patients. And so as these things come about and the next generation comes about, I think we'll find the answers and figure out how to treat these patients.
I can tell you, Zap, we're really committed to trying to find. I mean, it may not be me who presents that data to the world, but my successors will present it 15, 20-year data. So we just got a few more minutes here, but sometimes these tumors are big. You can present with a 4-centimeter tumor. And so what is too big for radiosurgery? And if it's too big, when do we think about maybe a combined approach? We're using selective surgical resection combined with radiosurgery. And is that an option? Again, you're the triple threat, so you should be able to do all of this stuff.
So I think big is a subjective word. I mean, if you go to different countries and you say, what's too big? That's going to be very different than coming to America and saying, what's too big in America? Like, the word big is subjective. And even in the past 20 years, I think big has changed. It used to be 2 centimeters, then 2.5, then 3, then 3.5. And now, as you said, there are centers and studies that treat up to 4 centimeters. And so I think the envelope is slowly being pushed. I also think about, how do you measure it? Are you measuring the cisternal component or just the portion that's cisternal? And then you have to look at the mass effect. And then you have to look at the age. Is this a 4-centimeter acoustic in a 25-year-old or 75-year-old? And I think, even though big is subjective, I think it's okay to say that somewhere between 3 and 4 centimeters or bigger is going to be too big. And so based on the age, mass effect, and I know there's all these qualifiers, but the cisternal component, mass effect, and age, somewhere between 3 or 4 or bigger is going to be too big. And at that junction, I would advocate, some combination of surgery and radiosurgery, because I think that's going to lead to the best outcomes. I think if you try to do the safest surgery, you're going to lead to shorter surgical times, less anesthetic risk, and still making it a radiosurgical target and getting the long-term benefit that if the patient's less than 40 or 45 years old, you can be more aggressive. But if they're 40 or older, you may want to do something like a combined or a hybrid approach, because you'll have the best anesthetic, surgical, and OR time and outcomes research. And that's not proven, but that's my opinion.
And when you're doing resection, where do you leave tumor? In the porous?
So when I do surgeries, the most common location where I leave tumor is the porous, because that's where it's most adhesive. And at that junction, my advice would be to drill out the IAC and try to attack it from both ends, because sometimes that frees it up. But sometimes you do that and it's still really adherent. And so then if you start seeing a drop in your facial nerve monitoring, any kind, if it goes from 0.1 to 0.3, and I'll hear people say, well, 0.3 is still functional. And I say, that's true, but you don't want to risk it. Any movement in your baseline facial monitoring, to me, if most of the tumor's out at that point, I say the bang for the buck is greatly diminishing. That's why we have radiosurgery, which is a fantastic, phenomenal adjunct. And so I would recommend stopping there if your facial nerve monitoring changes.
Perfect. Well, look, Isaac, I think you've given us a great tour of contemporary radiosurgery for acoustic neuroma. I really appreciate you giving us the time today. It's never hard. It's always hard to say something nice about a guy from UCSF, but I'll say something nice about you, Isaac, and appreciate you doing what you did today, and keep up the good work at UCLA, and hope personally the two of us can cross paths soon. So thank you everyone for joining us, and stay tuned for next week. Okay, take care, Isaac, and thank you.
Thank you, Dr. Adler. It was an honor. Bye.
My pleasure.